Hi, everyone. My name is Shabir Musa, a family physician from Johannesburg. We used to run it as the Joburg Family Medicine Department CPD meeting for doctors in Johannesburg. But since I've taken it over for a month or so, we're trying to appeal to a whole wide audience across the continent under the banner of the African Forum for Primary Health Care. So we'll just see if we can get a sense of who's attending. So I'm going to share a poll, and this will be helpful while I introduce our guests. We're really fortunate in having members of the Chris Hani Barrow Academic Hospital and Wits University circuit there that are always stepping up to help us, to tell us, to help the Johannesburg Health District doctors. And I think that it's always been very valuable and very useful. Today we have Dr. Theunis Botha and Sumi Thomas, who are internal physicians in the Chris Hani Barrow Department of Internal Medicine. And they're going to talk about the management of metabolic syndrome. So for you, Sumi and Theunis, we have about 19 of the 29 who have shared with you. Let me just end the poll now. I think that's 19 out of 30. Looks like no one else will do it. So let me share it. So you have a sense of who you are talking to. It's basically 2 family physicians, 16 interns, there's 1 medical officer, most of them South Africa and Gauteng and in Johannesburg. So you know your audience. Go ahead. And thank you for filling that in.
All right.
You can take over. Sumi, will you start or Theunis? And
yes,
if you need any
I'm going
assistance,
to start.
All right, go ahead.
I'm just going to close this. So good afternoon, everyone, and many thanks for inviting us for this talk. So myself and Dr. Botha are both endocrinology fellows at Chris Hani Barrow Hospital, and we've been tasked to share with you today management of the metabolic syndrome. So the outline of our talk, I'll do the first part, which is explaining what is the metabolic syndrome and how to define it, and why is it important to define. And then Dr. Botha will talk about the prevention and important aspects of treatment. So I'll start with a small quiz just to jog our memories, and everyone can do this on their own. So I have 3 statements, and please can you just answer by yourself, do you think these are true or false? So is obesity a prerequisite for the diagnosis of metabolic syndrome? Does the pathophysiology of the metabolic syndrome involve inflammatory cytokines? And should all patients with the metabolic syndrome receive aspirin for primary prevention? Okay, so why did this term, the metabolic syndrome, come about? We know it was first coined back in 1977, and this was by a physician who noticed that certain diseases conferred an increased risk of cardiovascular disease or atherosclerotic vascular disease. And he grouped these, and that's where it started. However, in contrast to this, we also know that not all obese individuals are unhealthy or at risk. So we can look at 2 different phenotypes. We can look at a patient who's normal weight, but is actually metabolically obese, and contrast this to a patient who has increased weight, but is metabolically healthy and never develops any of these diseases. Thus, there's more to it than just being overweight. The central aspects of the metabolic syndrome involve insulin resistance and hyperinsulinemia. Again, the type of adipose tissue is important. So the adipose tissue produces adipokines or pro-inflammatory cytokines that can cause endothelial dysfunction amongst other effects. And this specific adipose tissue is visceral adipose tissue. So if we look at the distribution of a patient's body fat, more visceral versus subcutaneous adipose tissue puts them at risk. Lastly, there is a genetic influence to this. In studies done of the normal weight metabolically obese patients, certain gene loci have been found that have conferred an increased risk. These are not common enough to test, but it just gives us, we must keep a high index of suspicion, even for the metabolic syndrome in a normal weight individual. The prevalence of the metabolic syndrome definitely is on the increase, and this is parallel to the obesity pandemic. As our population gets urbanized, we now have much easier access to calorie-dense food, and generally as a population, we're a lot more sedentary. Looking at epidemiological studies, non-communicable diseases now outweigh communicable diseases as causes of mortality in the majority of developed countries, and it's trending in this direction in developing countries. The prevalence of the metabolic syndrome is estimated at about 20 to 30% in large cohort studies such as the NHANES and the Framingham cohorts. Within South Africa, our smaller cohort studies have a similar prevalence. And in our studies, what we've specifically noted is that the African and the colored populations have a higher risk than Caucasians, as well as Indians, and females tend to have a higher risk than males. So what are these specific metabolic risk factors we're talking about? So these are fourfold, that being hypertension, intermediate hyperglycemia, or specifically an abnormal fasting plasma glucose, as well as the presence of diabetes, dyslipidemia, specifically being a high triglycerides or a low HDL, and lastly, an increased abdominal circumference. Here's some other names for the metabolic syndrome that have been named along the years. So if we look at definitions of the metabolic syndrome, as you can see here, there's quite a few that have been developed. These two are the most important and most commonly accepted. So the first one was the National Cholesterol Education Program Adult Treatment Panel 3, which first was developed in 2003 and then updated 2005, as well as the International Diabetes Federation, which was updated in 2009. If you do take time and read this table, you'll see that there's subtle differences between the two. If you look quickly, it looks like they're exactly similar. So let's talk about these differences. So the first criteria was the NCEP-ATB3, which looked at 5 different criteria, being hypertension, a low HDL, increased triglycerides, impaired fasting glucose, and your waist circumference. And any 3 of these criteria would define the metabolic syndrome in a patient. The IDF opposed this, and this was in 2006 and again in 2009, and they said that waist circumference was mandatory for the diagnosis to be increased, thus a patient had to be obese. Then further along in 2009, all these panelists met and developed the harmonized criteria, which they refined and all agreed upon. So there's certain differences we now see. Again, they've gone back to any 3 criteria will define the metabolic syndrome. Thus, a patient does not have to have an increased waist circumference. Secondly, studies now tell us that waist cutoffs are different in different populations. And now we have different levels dependent on your ethnicity. Lastly, there was an argument about whether diabetes should be part of the criteria, because the initial purpose of the criteria was to prevent the occurrence of type 2 diabetes. However, they agreed that diabetes should be included amongst the other criteria. So we talked about the waist cutoffs. When the criteria first developed, the waist cutoffs were much higher, being 102 centimeters in males and 88 centimeters in females. This has been refined by studies. In the newer definitions, we know by ethnic variations that Asian populations have a much lower cutoff because they have a much higher total body and visceral fat percentage compared to other populations. Thus, we use 90 and 80 centimeters in these patients. Again, the harmonized criteria revised again the waist cutoffs, and now we use 94 centimeters in males and 80 centimeters in females as cutoffs. So here we can see this displayed nicely. So in any European population, it's 94 and 80. In the South Asian, Chinese, and Japanese, it's 90 and 80. Here in South Africa, which is the sub-Saharan population, we're advised to use European data because we don't have country-specific data. And of interest, anyone from South or Central America is advised to use South Asian recommendations. until further data is available. So is it really important to identify the metabolic syndrome? And there's been a lot of cross debate about this. Some believe that you should rather just identify the individual components and treat them specifically, and the other proponents for identifying the metabolic syndrome. So these arguments are that the metabolic syndrome, whichever disease you have, all increase the risk of type 2 diabetes, which we know is an independent risk factor for vascular disease. Secondly, by identifying one component, you'll actively try and screen for and prevent other components of the metabolic syndrome. And lastly, the complication of the disease, which is atherosclerotic vascular disease, you'll be more tuned to look for this and to try prevent it. So how much are these risks actually increased in a patient with metabolic syndrome? So we know a patient with metabolic syndrome, in studies, the relative risk for having type 2 diabetes is about 3 to 5-fold increased. And to have vascular disease is 1.5 to 2 times increased. So it is a much larger risk that we should be worried about. Let alone these two risks, there's many other diseases associated with obesity that we can improve morbidity in the patients. Of concern, non-alcoholic fatty liver disease is becoming a lot more prevalent, and we know now is the leading cause of transplant in the US and other Western countries, as well as other diseases such as chronic kidney disease and obstructive sleep apnea that we must look for. So I'll hand over to my colleague, Dr. Botha, for the remainder of the talk.
Thank you very much, Simi. I just want to quickly see, I can't take control over your slides. So if you can stop sharing, then I'll just share from my side. Okay, there we go. So sharing that one. Okay. I see it now, sharing my slides.
It's starting, but somehow not seeing it.
Let's give my computer here, Prof. Oh, let's see.
If you cannot find your document, your presentation, just close the share screening and open your document and then start share screening again. So just close that share screen, open your presentation, and then you should find it.
Okay, let's see quickly.
But you have to close the share screen, otherwise it won't pick it up.
Yes, that's what I'm just quickly trying to find. Come on, computer. The other option is if you can maybe load. Oh wait, there we go. There's something.
Is it working? Otherwise, I can share.
Yes, otherwise you can share it, and then
I think Sumi, if you can, just I think it'll allow you to stop him sharing. Good.
Okay, there we go.
Okay, are you on the prevention and treatment slide?
Yes.
Awesome. Thank you very much, guys. So today
before you go on, I think we're not seeing your sharing. I have to stop your screen sharing.
Oh,
all right, I'm going to just see if I can allow. All right, there we go. Go ahead. We can now see Sumi's screen.
Okay, awesome. So very important, the prevention and treatment of the metabolic syndrome consists of exercise, diet, pharmacological aspects, as well as metabolic surgery that we will just briefly discuss in these patients. So the prevention of metabolic syndrome really dates back to the diabetes prevention program, and also mostly important lifestyle intervention. If you look at the study, it showed that a healthy low-calorie diet, a low-fat diet, and also moderate physical activity of at least 150 minutes has resulted in significant weight loss. And associated with that, there was a significant reduction in the metabolic syndrome of about 41%. Sorry, guys, I just want to see my slides. Even on this side, doesn't want to advance.
I can advance for you.
Cool. Okay.
Are you looking for your notes, Tunis?
Oh, he's left us.
I'm sure he'll be back in a few secs. Let's give him a second. I think his computer must have frozen. If there are any questions for Sumi on some of the material she's presented, please feel free. I just want to remind you that you can look at either raising your hand if you want to speak, or if you can just add into the Q&A. And if you have any other comments, or otherwise you can use the chat as well. So feel free to use any of those to communicate. So Ksumi, if I may ask this question while we're waiting for Tunis to join us. So in the South African setting, you said that we are using the European of a male adult 94 centimeter for abdominal circumference. Is there any differentiating between different communities or so ethnic groups in South Africa? You mentioned colored and in colored and black. The white population, I assume, is fine. But what about the Indian population?
Yeah. So there's been no clear recommendations to use different cutoffs for different populations. But there have
in South Africa.
Yeah, specifically in South Africa.
Mm-hmm.
But there have been cohort studies. So specifically, Prof. Matala did a study on a cohort in Durban, which included a lot of Indian patients.
Right.
And they looked at this cohort over time and looked at complications and vascular disease that happened and compared the waist cutoffs. And we did find that in the Indian populations or Asian, South Asians, a lower cutoff was identified. So there probably is a need to try and segregate waist cutoffs for different types of populations, but we're not there yet.
And what is the cutoff? 90 as well in the so Prof. Mutala's cohort, or did they come up with a different measure?
So I think for males, if I remember correctly, it was somewhere around 86. And for females, it was close to 80.
So it's much less than, in fact, the this South Asian definitions.
Yeah, I stand to be corrected on the exact numbers, but it was closer to the South Asian cutoffs than the European cutoffs.
But it's not uncommon to find very thin Indian males, but having a tummy, and they'd be the problem.
Yes.
If they had hypertension and diabetes and dyslipidemia, they would be your problem patients that you need to not ignore.
Yes.
We still haven't got Tunas on the line. Perhaps you can give them a call, Sumi, just to find out. If needed, you could perhaps just... Michelle, I think, would you like to speak? Go ahead. Dr. Tulute is a family physician in Johannesburg. She might have a question for you. Go ahead, Michelle.
Good afternoon, everyone. My question is just around low-fat diets. I know that's a term that's kind of thrown around, but it's often associated with a higher sugar diet. So I don't know. I'm still trying to get my head around this low-fat versus
high-fat Banting diet.
Yeah, exactly.
What's your take on that, Sumi?
So I think it's quite a loaded question because what we're coming to realize and what we've been taught, especially by our seniors, is that not everyone behaves the same, their bodies. So certain type of people will respond to certain types of diet better. For example, some people may do very well in a ketogenic diet, whereas others will do extremely well on a low-carb diet. And we still don't know what these specific identifiers are. And that's actually the future of treating patients' diabetes, is to know how to individualize treatment and diet for a specific person. We have some information in the right direction, but yeah, it's hard to specifically pinpoint that. But I think in a diabetic patient, whatever diet you're taking, you still have to lower your sugar content at the end as the bottom line.
So can I ask a favor? I don't seem to find Tunas's number easily. Would you mind quickly giving him a quick call to see if he's going to be able to join us? I mean, in which case you could perhaps just finish it. I'm struggling with finding his number. I have it on my computer. Let me just see.
Yes. He said he's having trouble getting back on, but he's attempting. We can give him just a minute or two more.
All right, that's fine. So if there are any other questions, you basically said that that diets will, these various diets will depend on people, and so there's no real good marker for which patients you might do that. And I'm sure that's the kind of work that could be done by family physicians, in primary care settings to look at that kind of thing. And do you know of any other work in South Africa that is being done on diet and the different types of diet? Yeah.
So there is some work looking at the ketogenic diet in patients with diabetes. There was an endocrinologist in Joburg. It was her area of interest, and she did her PhD around this topic.
Right.
So yeah.
Any idea of what she came out with? Is it any more than what you just told us?
Yeah, so she's a strong proponent of the ketogenic diet, but obviously watching other metabolic parameters like your lipids quite closely. But in her small cohort, she had excellent results.
Interesting. Any other question? Michelle, you have got your hand. You can unmute yourself if you need, unless it's an old hand.
Oh, lower hand.
Okay.
Just a mention on that ketogenic diet, isn't it incredibly unpalatable? And it works in like tiny babies for epilepsy syndromes, but it's not a very palatable diet as far as I know.
Not really, Michelle. It doesn't need to be. I mean, a juicy steak with lots of fat is really tasty. It might be that you have
It's a high-fat diet.
more the fat. It is, but I mean, you're looking at lots of, I don't think it's necessarily eating butter or eating fat in a way that's unpalatable. But there's a fair amount of fat in our diet that we can. In fact, I think mostly it's about reducing the amount of carbs, marginally increasing the amount of fats. But yes, Sumi, what do you think?
So I know I probably wouldn't cope with it, but I think
because of the lack of the carbs, I think.
Probably, yes, and the variety. But I think if we look at the Western world, at people's diets, and they probably eat the same amount of meat and fat, plus carbs. So I don't think we're actually adding more on. I think we're actually, for the majority of people who are very overweight in the Western world, we're actually just removing the carbs and leaving them on the rest of it.
Yeah, and that's what I've actually worked with someone who sort of insisted on it. And I was just looking at the mix of the diet. And to me, it was a lot about reducing the carbs, which is not a bad idea considering the amount of carbs we have. I'm not sure that, too much. It's probably just the ratio difference that's creates a ketogenic effect.
Yeah.
Any other comments from anyone? I think we've got someone who's asked a question. Yashodini has asked, what is the effectiveness of bariatric surgery in helping patients with metabolic syndrome? I think that's kind of what Tiernes was going to talk a little bit about, but you can go ahead and answer that. Do you have any studies on bariatric surgery? I mean, clearly it is an option.
Sorry, I was on the phone with Tiernes.
All right.
His computer is completely frozen.
Yeah, so don't worry. I think let him not stress. I think we just sent him a message not to. Will you be able to continue with the rest of his slides?
Oh, I haven't practiced them, to be honest, at all.
Just go through them, and whatever you think you can talk to, that should be good enough. I think don't worry about doing it more. Then you can talk offhand. It's fine. And you can talk to the effectiveness of bariatric surgery in that answer, in that presentation. I think just to pick up another question in the chat, studies on vegan diet for the treatment of metabolic syndrome. So let's leave you to go through the rest of the slides. Do the best you can, Sumi. It's not a deal. And then we'll pick it up with question and answers. And if Tiernes can join us, he could answer some things as well. Go ahead.
Okay, so I'll attempt. So Tiernes covered the prevention and treatment of the metabolic syndrome. So there have, as he spoke about, there have been a large number of diets that looked at trying to prevent the occurrence of the metabolic syndrome or any other further components. So here he's mentioned the diabetes prevention program, which looked at the low-calorie, low-fat diet, including physical activity, which resulted in a 41% reduction in the metabolic syndrome. Sorry, so here he's saying that the Endocrine Society doesn't recommend a specific diet. The recommendations according to the SEMSA guidelines is for moderate intensity exercise. So what's recommended is 45 minutes of brisk exercise, at least 3 to 4 times a week, or 30 minutes daily as a minimum. And when we say brisk walking, it's to a degree where your heart rate increases and where you start sweating. So often it's not when patients are simply walking towards the area of residence or walking within work, it has to be dedicated exercise. And we recommend a healthy lifestyle from the Endocrine Society. And this, you can adopt any form of diet for this to try achieve the recommended weight loss. So pharmacological prevention, there have been a lot of agents that have been looked at and a lot of agents that do cause weight loss. But at the moment, there's no approved agent specifically to prevent the metabolic syndrome. There are agents that are approved, such as the GLP-1s, for the incidence of weight loss. So here they looked at metformin's use within the DPP study, and we said that it reduced the incidence of metabolic syndrome, I think it was by 41%, and reduced type 2 diabetes by actually 31%. So here,
Dr. Thomas.
Sorry.
I think I'm back there.
Fantastic.
Sorry about that, guys. My computer just gave me issues. Okay, so when you look at American Diabetes Association, you will find that they recommend to prevent type 2 diabetes, which is obviously a big part of the metabolic syndrome. It is important to use metformin in a specific population, and this is specifically the guys with pre-diabetes, those with a very high BMI, those aged less than 60 years, and those women with prior gestational diabetes, essentially. And this is from the most recent 2001 Standards of Medical Care in Diabetes from the American Diabetes Association. Okay, can move on now.
So can you change? Yeah.
Okay. So when we look at the treatment of metabolic syndrome, it's sometimes easier to look at it in with the individualized aspects of the metabolic syndrome, and we'll discuss a bit of the diabetes, the dyslipidemia, the hypertension, and then obviously the weight aspect of it. So when we look at diabetes, the diabetic treatment guidelines in South Africa are very well set out with the SEMSA, within SEMSA guidelines, 2018 SEMSA guidelines. And you'll notice there that monotherapy or first-line therapy is still metformin. A lot of studies have looked at metformin. It is actually a very nice drug to use with metformin. So I think I've skipped the polypill slide, so we can just go, I'll skip that for now then rather. Continue there. Okay, sorry. So when you then look at the SEMSA guidelines, as I mentioned, metformin is still for monotherapy, and most of our patients will start on metformin therapy. It's very widely available and quite affordable for our patients. When you look at this guideline from 2018, you'll notice that second line, which were then there as the DDP4 inhibitors, as well as glycoside MR was recommended as second line. And often in the primary healthcare setting or in the state sector, we don't have all of these other agents that are mentioned, the SGLT2s or the GLP-1s. And we are expecting, however, from SEMSA to actually update this guideline either this end of this year or next year. So we should be looking out for new improved guidelines from the South African setting as well. But when we look at the American Diabetes Association guidelines, you'll see it's a much more complex guidelines, much more complex algorithm as well. Again, they still use metformin therapy as first line, but then after the metformin, they start looking towards the SGLT2s as well as the GLP-1 receptor agonists rather. You can maybe just go to one slide there, you'll see that when after metformin, you should then start individualizing your patient and especially look at your patient and their atherosclerotic cardiovascular risk. If they have a lot of atherosclerotic risks, you should consider possibly a GLP-1 receptor agonist or possibly a SGLT2 inhibitor. But if you have a patient that is high risk for heart failure or who's got heart failure already, patients who already got CKD, then you should rather consider SGLT2 inhibitor in these patients. So as you can see, even from the ADA guideline, metformin is still the first agent to be used, but after that, you need to start individualizing your treatment for your patient. But nice about this guideline and nice about this diagram is you can also see they incorporated a lot of other aspects. Like on the right hand side, you can see cost. Cost is a major issue. You can still use the SUs for those patients. If you have a patient where you want to minimize the hypoglycemic episodes, again, recommendations will then look towards your DPP4, your GLPs, as well as your SGLT2 in those patients. Okay, next. I think from a primary healthcare point of view, it's very important to look at what is the diabetic target that we want to try and achieve. And again, it needs to be highly individualized for patients. And when you look at an HbA1c, HbA1c of 7% is probably what we can use for most patients. But when you have elderly patients with high risk of hypoglycemia, you need to adjust that HbA1c target, maybe around 8 or even 8.5. Or if you have a much younger patient that is highly motivated, with a very good self-care capacity, then you can probably look at the HbA1c target of around 6.5 to 7% or even around that side. We often find patients coming into our clinics with sugar levels of around 8 or 9 or 10. They tell you, oh, doctor, but my sugars are not that bad, are it? And I do think it's very important that we should be aware of the blood target levels that we should look at and really focus on maybe explain to our patients that this is the targets we should aim to achieve and to actually minimize your target organ damage in your patients. When we look at the next aspect of metabolic syndrome, hypertension. Hypertension, as we know, is very common in our setting, and there are multiple agents to be used for hypertension. Just a few words on thiazides and the beta blockers. They are currently or most are oftenly discouraged in the metabolic syndrome because they do have the potential to cause weight gain, especially in your beta blockers, and that will then worsen your glucose intolerance and dyslipidemia. They also have some dysmetabolic effect, as in the thiazides. When you look at a calcium channel blocker are regarded as very neutral in the use in metabolic syndrome. And the best or the agents with the most benefit is possibly your RAS inhibitors, your renin-angiotensin system inhibitors, like your ACE inhibitors or MRAs or ARBs, etc. I think an important thing to know is that blood pressure targets need to be achieved in your patients. And I think it's from both the patient point of view, but also a lot of physicians are very reluctant to increase antihypertensive medication. They're very reluctant to get a patient to target. We often see patients coming in with blood pressures of 140, being on the same agents for the last 5 years, with nobody actually escalating their therapy. So when you look at this algorithm from that was published in Hypertension Journal, you'll see that the normal blood pressure is less than 120/80. But as soon as you go towards 120 to 150, you already need to start talking to your patient about blood pressure control, optimizing the control of the blood pressure, and then continuously reassess the blood pressure and act as soon as you can see there's some abnormality developing. When you have a patient with stage 1 or stage 2 hypertension, this is now being regarded as a blood pressure of a systolic blood pressure of more than 130, you need to start acting more aggressively and start pharmacological agents already in these patients. You can see there, if there's any comorbidity like diabetes, chronic kidney disease, heart failure, those patients need to have a blood pressure goal of at least 130/80. Thanks. The next aspect we need to address is the dyslipidemia. As you know, as we saw, there's a lot of LDL guidelines on the definition of LDL and triglycerides. And unfortunately, most of the guidelines we have for dyslipidemia focuses on an LDL level. So many patients always want to ask, should I start on a statin? And the important thing is to assess a patient's risk. And I think you guys are all aware of the 10-year risk for atherosclerotic cardiovascular disease. And there's many scoring systems or calculators we can use for that. The most common one we use is probably the Framingham heart study score. Now, other ones are the score risk charts, and there's also something called the ProCam calculator. Luckily for us, we don't need to remember everything off by heart, and these you can find on any app. Most of the apps will have it. QX Calculate, they do have it. EM Guidance app on your phone will have a calculator for this, and I think it's important to start using this when we talk to our patients about metabolic risks. So I'll show you guys a few examples of these charts. This is the Framingham heart study charts that I can use. And you can see there's different ones for women and men. And it's very easy to use. Basically go from step 1 to step 7. You calculate all the points together, and then you will get an equivalent risk essentially for your patient. And the next slide will show you the score chart. And I think that's a bit more easier or very nice to print out, have it in your office or close to you, and you can use it very easily. And this is from the Journal of the American College of Cardiology. And again, you will see it encompasses male or female, smoker, non-smoker. It encompasses your blood pressure as well as your cholesterol level, in this case, your total cholesterol level. And by using this, you can then get a score for a patient, which will then translate to a percentage. And that percentage is your percentage of having either or having cardiovascular event within the next 10 years. Thanks, Sumi. You can move on. So another question is, should everyone be getting a risk assessment? And the answer is no. If you're already at high risk, and you can see here in the top corner, in the green block, if you have an LDL of already more than 4.9, you don't need a risk assessment. You're already high risk, and you need to start a statin therapy in this patient. Just below that, you'll see diabetes mellitus and age 40 to 74 years. Again, you're already at high risk, and you need to start some statin therapy in those patients as well. Then when you look at the other columns, you'll see age of 40 to 75 years of age with an LDL between 1.8 to about 4.9 without diabetes. And those are really, I think, quite a majority of our patients we see. And in them, it's recommended to do a risk assessment. So this again is from the American Heart Association. You'll see that they've got their risk assessment look at a low risk if you score less than 5%, or a very high risk if you score more than 20%. But the important thing here is to know that if you're intermediate risk or if you're at high risk, you need a statin therapy. And even if you are low risk or borderline risk, it's important to have a discussion with your patient about their risks and to involve them in making a decision about, are we going to change lifestyle? Are we going to increase exercise? Or when will we start a statin? And show them the recommendations that are currently available on that. When we look at the South African guidelines for dyslipidemia, you'll notice that our guidelines, again, about 2017, 2018 guidelines that has been published by SI Heart and LASA, you'll see that they also recommend to use a risk assessment tool for any patient at risk. So I do feel that any patient coming in with features of metabolic syndrome probably are already at that level where you should do a risk assessment for them. Again, patients with very high risks, they don't need a risk assessment. And they are your known cardiovascular disease patients, your diabetic patient, your chronic heart or chronic kidney disease patient, as well as severe dyslipidemia or genetic dyslipidemias. And South Africa uses the same guidelines as the European Association, or the Europeans, and you'll see there that if you have a very low risk or percentage, so you've got a low risk, Framingham score less than 3%, you've got an LDL target to set of 3 millimoles per liter. And you'll see there is a bit of a difference between this one, this algorithm and the one before, that very high risks in South Africa or the European countries start at more than 50%. Whereas they use a cutoff of more than 20%. Importance is that we need to look at the targets and to try and achieve these targets for our patients. The target here you'll see is less than 1.8 in your very high risks, but there is also now a movement to even lower it further to 1.4 millimoles per liter, especially in your very high risk population. When we look at how are we going to achieve this LDL reduction, it's important to use the correct type of statin. So on the next slide, you'll see there is a list of statin therapies. Okay, and I think the important thing is to choose the statin that will get the job done. Okay, when you need to lower your LDL cholesterol by more than 40 or 50%, it doesn't help using simvastatin. You're not going to achieve that goal. We often see patients being on simvastatin with high LDLs, and nobody bothered to change them or to consider changing to a different medication. So I also think it's important not to just look at the level or the target you need to achieve, but also to look at how I am going to achieve that level and what type of statin I will be using for these patients. Lastly, we'll be looking at other causes, obviously other causes of high dyslipidemia. But first, remember, if a statin is not enough, you're still not achieving that LDL level, there is some other medication available. Ezetimibe you can use. There's about a 20% decrease in your LDL level with ezetimibe might use. And then obviously your newer agents, your PCSK9 inhibitors, which is very expensive and not widely available in the primary healthcare setting and state setting. But they do have very good LDL reduction abilities of more than 50% to 60%. Just having a quick look, when there is a high LDL, don't forget to exclude some other causes. It's maybe not just cholesterol. Patient might have some other disease process going on. So very important to look at these other causes for hypercholesterolemia and to exclude these causes before starting a patient on a statin therapy. So the last aspect of the metabolic syndrome is obesity and weight circumference. And I think this is probably one of the biggest issues we have in treating the metabolic syndrome is reducing the obesity and that weight circumference. And when you look here at the Endocrine Society recommendations, you'll see that diet and exercise and behavioral modification is all part of it. And when you have a BMI above 25, diet, lifestyle changes are recommended. But as soon as you get to BMIs above 30, above 40, you will need extra support. You will need pharmacological therapy. You will need bariatric surgery. And it is recommended that you use bariatric surgery in your extremely or severe obese patients. Again, if patients have comorbidities, that threshold should be lower. You should have a much lower threshold to start pharmacotherapy in a patient with a lower BMI with comorbidities, as you can see from these guidelines and the recommendations. When you go to the next slide, you'll see that the problem is that patients always want to know, but how much do I need to lose? And this is a very nice table looking at different disease processes and essentially the recommended weight loss target. And so I think when you look at it and just screen for it, you'll see that about 10% is probably the magic number. People need to lose about 10% of their body weight to really achieve good outcomes. But I always tell my patients, you know what, it's not about exactly how much, but let's start with 1 kilogram. And I think that's important, is to start that conversation and to start small, but then to have some aim or some weight target at least to set for your patient, which is achievable for your patient as well. The biggest issue we face with treating obesity is the limitation we have in drugs available to treat obesity. So you'll see this is quite a bit of an old slide, but from 2015, but you'll see the drugs currently being used or available and FDA approved essentially is your Orlistat, phentermine, topiramate, naltrexone with bupropion added onto it. And the nice thing or the bad thing about these agents are they've got very limited weight loss abilities. Weight loss abilities in most of these cases are only less than 5%. Okay, and often we need a lot more weight loss percentage in your patients. So, although these agents are available, they're not very good at reducing weight. They also got a lot of side effects which patients complain about. And I think more recently, the newer agents, again, GLP-1 receptor agonists are going to change the whole field for diabetes, but also for obesity management. You'll see there at the bottom, we've mentioned the liraglutide that is now available. This is the higher dose daily injection of liraglutide. Victoza was the first coming out. Sadenza is now available specifically for weight loss. And you'll see that there's about 5.8 kilogram weight loss in 1 year. They recommend that if you don't lose more than 5% of your body weight after about 14 weeks, then you should stop this medication because it will not be effective. But in practice, we've seen very good effects of the GLP-1 receptor agonist in weight loss. And anything from about 5% to up to 15% of weight loss is recorded in these patients. The newer agent, the semaglutide, is quite nice. This is a weekly injection. Again, being a GLP-1 receptor agonist, is mainly used for diabetes currently. The Ozempic, I know Ozempic is being launched now very within this month or so in South Africa. But I think the big game changer is going to probably be the semaglutide 2.4 milligrams subcutaneous weekly dose, which will come out later, either this year or maybe next year. And you'll see there the weight loss percentage, 15% of weight loss that you can achieve with these newer agents, these GLP-1 receptor agonists. So I do think, in view of obesity management, this will change the scene there. Just a briefing about metabolic surgery. There are many different types of metabolic surgery available. I think from a primary healthcare point of view, it's important to discuss metabolic surgery with your patient, the option, especially in your metabolically very obese patient. This is probably the most effective way to lose weight. It's also very good for diabetes remission. The problem comes in that there's a lot of psychological aspects to it. You need a multidisciplinary team to get involved with this patient, the surgeon, the endocrinologist, the primary healthcare physician, which will look after the patient later on again. So I think when you start looking at metabolic surgery, it should be a team approach and should be kind of like advised on, especially in your obese patients. So that is essentially the management of metabolic syndrome. And then just a quick thing on aspirin, because the question was asked earlier there by Dr. Thomas. So should we prescribe aspirin? We often find a lot of patients coming to us with a box full of medication with aspirin included in it. And for secondary prevention, definitely. Every patient should be on aspirin for secondary prevention. For primary prevention, however, if you look at about 10 years ago, it was probably recommended for everyone. A lot of people were put on aspirin, but it is a high bleeding risk. So more recently, the American Heart Association made a recommendation to say that low-dose aspirin, 75 to 100 milligrams orally daily, might be considered for your primary prevention, especially for your atherosclerotic cardiovascular disease, if you have a select population, patients that are about 40 to 70 years of age, who are at a high risk, but have a low and not an increased bleeding risk. So again, not a clear answer there, but again, nobody should be on aspirin just because. If you have a good reason with high risk, you probably can use aspirin for primary prevention. Thank you. So let's quickly just go back to the last slide. Test yourself, true or false. So obesity is a mandatory prerequisite for the diagnosis of metabolic syndrome. True or false? False. The pathophysiology of the metabolic syndrome involves inflammatory cytokines, which is true. And then all patients with the metabolic syndrome should receive primary prevention. We know that is false. Thank you very much.
Well, thank you. Thank you to Tinus and to Sumi. Appreciate your persisting despite the challenges. Quickly, Thomas, there was a question by, I think you might see it, might not see it in the chat. Nikita asked the question, have there been any studies of vegan diet on metabolic syndrome? And there was an earlier discussion we had on the sort of Banting ketogenic diet. Do you want to tell us a little bit about that or respond to it?
So I actually don't know of any specific diets myself in the vegan or vegan diets. I'm sorry, I can't answer that. I'm not sure if TNS is aware of any.
Okay. Any comments, Tianis, on vegan or banting diets?
Not really with regards to the vegetarian or vegan. Banting, from my experience, we have seen it losing weight. We have seen patients losing weight on banting, but we also have seen very high cholesterol developing with the banting diets, especially with the high fat content included in the banting diet, and patients actually having myocardial infarctions while being on a banting diet. So I do think there are risks involved with it. I do think you should look at the patient in a holistic way and see what is really the issue here. Is it the weight? Is it from a diabetic point of view? And maybe try to address it in a different way. But from a banting point of view, the biggest issue I have with it, I do love the low carb aspect of it, but the biggest issue I have with it is the high cholesterol and the high fat content, which we have seen patients being getting very high cholesterols.
So patient specific. Yashardini Mupin asked the question about what is the effectiveness. You've talked about it, but how effective is it, and how would you sort of use it in your spectrum of options?
Could you just again?
What is the effectiveness of bariatric surgery? I mean, you brought it up as an option.
Okay.
How effective is it if you do resort to it?
So we do see weight loss of around 15 to 20% with bariatric surgery. So very effective. But again, now with the GLP-1 semaglutide, we already see the 15% weight loss. It might be a much safer option. And that's why I do think it will start revolutionizing the aspect of obesity, especially. But yeah, there's about a 15% weight loss in bariatric surgery. So very effective.
Right. There's a couple more questions. Just to tell anyone listening in, we will make the presentation available on the webpage where you registered, and the recording is already there. So I'm going to just allow Lorenzo to speak. In the meanwhile, I just want to ask the question by Adrian Koopman, who asks which blood pressure parameter is more important, diastolic, systolic? He says he sees patients with high systolics above 130, but normal diastolics. I think he's talking about the sort of way to manage the hypertension patient that you talked to.
Yeah, so I can try to answer that. So
go for it. Yeah.
I think we must just bear in mind the factors that alter your systolic and diastolic. And the systolics are the one that will change quicker with anxiety, caffeine, exercise, food intake, other drugs, any number of other factors. Whereas the diastolic is a lot more stable. So
better predictor.
Better predictor. So white coat hypertension. So I think looking at all of that, we need to look at both, because we do get isolated systolic hypertension, and we can't always attribute this to anxiety. So we need to measure blood pressure in the right way if we're concerned about a patient with a systolic that's always high, or perhaps ambulatory.
Yeah, and Sumi, would the age not influence the systolic as well?
Yes. So
does systolic not rise with age?
It does. You have stiffening of your large arteries with age. So your systolic tends to become higher with age as well. It's also something to bear in mind.
Okay. Good. Lorenzo, you can go ahead.
Great, thanks, Prof.
Yes, go ahead.
Thank you, Dr. Woods, and thank you, Dr. Thomas, as well. Just a question that I think one or two of the interns have maybe seen in the clinic, in their various clinics where we are placed at the moment, is various patients that are hypertensive and not necessarily meeting the criteria of a metabolic syndrome yet, but are coming in with maybe uncontrolled blood pressures that have maxed out the Amloc, the hydrochlorothiazide, as well as the enalapril, and have been started on atenolol to try and bring down the blood pressure. And I think what you mentioned, I think it was Dr. Burt, you mentioned that to rather stay away from the atenolol and rather move towards a losartan kind of situation. Is there maybe a scoring system or paper that you can recommend for us to go through? Because according to the EDL guidelines, the next step after maxing out the first 3 medications, would then move to a spironolactone. But I think specifically in the resource constraint scenario where we are unable to have the regular follow-up, particularly of the blood results, and we're having such long follow-up periods, is any particular medication that you can say you would prefer in trying to decrease the blood pressure, with, again, keeping in mind without trying to exacerbate the underlying comorbidities?
Sure. I think it is a problem. We are very limited in what we have sometimes to use, okay? And although it is discouraged, there's no contraindication to use it. Okay, so you can use your beta blockers. There's also other aspects when you want to use a beta blocker, patients with heart failure, remodel therapy, patients maybe with ischemic cardiomyopathy, where a beta blocker will be advantageous for your patients. And in those patients, I do suggest you can use it so. Okay. So I don't think there's any specific contraindication as such to using it. It's more towards your patients where they do have some risk, they're not diabetic yet, but you maybe want to try and see if you can use something else. But if you're already on 3 agents, adding another agent is probably not going to be the worst for your patient. I would much rather have you treating the blood pressure adequately to reduce the patient's risk, rather than waiting or worrying too much about that bit of extra dysmetabolic syndrome or worsening of the metabolic syndrome, which is a possibility in your patients. But I do think you should aim to actually control your blood pressure as much as possible with the agents that you do have available. I currently don't have a specific paper as such that I can, or a recommendation I can make for that. But if you look at the hypertension guidelines from America, the Hypertension Journal, they do often have the latest guidelines. And I'm pretty sure you will find some good evidence-based medicine or guidelines from there as well.
Thanks,
Thank you.
Dr. Botha. I just want to, just add to that, you need to be sure that you're working up the patient for complicated or secondary hypertension. And in that case, CKD might be one of the investigations you were alluding to, but I think be careful of that. But on the other side of the spectrum, these patients are also likely to be non-compliant. And I think you need to really spend the time and energy, not necessarily with them, but arranging for the community health workers who are around and should be able to help you to go and visit this patient and see. There are often many times in these patients, non-compliance, but also social problems and difficulties that exacerbate the problem. So just make sure you've ticked that box off. I think we'll stop right now. I think Rutendo's got another question. I think, does anybody want to volunteer responding to it? If you can see it, he's asking about at what level would you start insulin in a new type 2, at what level of HbA1c? I think let's leave that. I think that's another question. And let's leave Rutendo to look at the diabetic guidelines that are available. The sensor has been mentioned. So let's close it at that. I don't want us to drip off we passed the hour. Once again, thank you very much, Dr. Tunis Botha and Dr. Sumi Thomas. I really appreciate you all coming and spending the time. The presentation, Sumi, would you mind just emailing it to me, to Tunis, and then we'll put it up there. You can have a look at it for all the details that you might have missed. There's also a recording of the presentation. Thank you all very much for attending, and we'll see you next week. Take care. Bye-bye.